Obesity is a pressing and complex challenge. GLP-1 medications are a game changer, but on their own, they may just bankrupt insurers without doing a whole lot to improve health. Can we build a better system for weight management that's clinically sound, cost-effective, and scalable? Hi, everyone. I'm David Williams, president of strategy consulting firm HealthBiz Group and host of the HealthBiz Podcast, where I interview top healthcare leaders about their lives and careers. My guest today is Elina Onitskansky, founder and CEO of Ilant Health, a value-based obesity treatment company that strives to improve access and reduce costs. Do you like this show? If so, please subscribe and leave a review. Elina, welcome to the HealthBiz Podcast.
Thanks for having me.
All right, so it's such an interesting topic. I want to start, though, in the way back times and ask you about your childhood and what it was like growing up, any childhood influences that have stuck with you throughout your career.
Yeah, so I'm actually, an immigrant. So my family's from the former Soviet Union, and we came over actually as refugees to the U.S. when I was about 6 years old. And like anyone pursuing the American dream, we went straight to Cleveland, Ohio, because naturally, that would be the first place that you would think of going. But no, I had, frankly, a great childhood in Cleveland. As you know, Midwesterners, very friendly, very nice. Great experience there. I would say one thing that was always true is my family is very big into education. And so that was just super core to what was important for them, super core to our, frankly, American dream. And a lot of what, I attribute sort of my life to, which is, the power of learning, gaining experience and being able to really sort of change what you're doing and sort of chart a course. That's a little bit of my background.
That makes sense. Well, the truth is that it may not have been obvious to someone coming from the former Soviet Union about what Cleveland was like, but it was obvious to the community leaders in Cleveland that they need to reinvigorate the place, and they invested in that, actually attracting people. So that was a strategic move.
I will say I don't live in Cleveland anymore, but I will give it a plug. Like great sports teams, great cultural locations, great healthcare. So it's a little bit underclubbed of city.
Yeah, good. All right. So in terms of education, I think you got a couple of Harvards in your background. Is that what I had seen?
Yeah. So I was part of that growing up. I was a giant science nerd. So I spent my high school years in the super cool activity of doing lab work. Actually ended up patented for a microsensor that I invented. And then went on to Harvard as a chemistry and physics major, thought I would be, frankly, a researcher, a professor. And then I realized, both I'm deeply practical. So I like things that actually have less than 100-year or 40-year timeline to sort of real human impact. And I also like people and they're, spending time and really sort of that extroversion factor. And so, ended up sort of pivoting into that business world, but with sort of a deep, I would say, for me, I was, chemistry and physics. I deeply believe the scientific method's probably like the most useful thing you can learn. Like, it's not about what you know, it's actually how do you figure out what you know and what is true and what is not true. And so, that was a bit of my educational journey.
That sounds good. So let's talk about early career after that. You did go into some business ventures along the way, a stint in consulting, some with insurance, some other things. What was that career path like before your current company? What were some of the key things you did? Were any turning points that you faced?
Yeah, so I'd say before business school, I did, generalist consulting and was a generalist private equity investor. Both of those were phenomenal experiences. So I was at McKinsey and H&F, which I think are, some of the smartest people I've worked with in both. Obviously, sort of McKinsey is an incredibly robust training ground on how do you think about strategy? How do you break down a problem? And, H&F, I learned so much about what I know of what makes a good business. How do you break apart businesses? How do the economics need to look for, a business to actually be functioning well and be valuable came out of there. And so I could not have thought of better, frankly, training ground experiences. And then sort of went to business school knowing, though, that I did want this sort of ownership and operations and impact have always been really important to me. Came out of business school, and having picked healthcare as my area of focus, partially because, actually do have a lot of family members in healthcare, but also it's just such a meaningful area that is just, frankly, so messed up. And so even at a younger age, I felt really strongly that there's going to be so much room to change things and have impact and drive value because it was just deeply needed. So actually spent some, went back to McKinsey, became an associate partner there, headed up their commercial service line, focused actually on value-based care and value-based insurance design. I think one of the things that's always interested me is like, how do you line up incentives, right? Because I think if you don't have incentives aligned, like everything else is just so much harder, right? And if you have incentives aligned, then actually like a lot of things work without like a ton of oversight and sort of process. So that's always been an area that sort of like fascinated me, which is like, how do you actually make things work better as opposed to what I think we often do, which is take a system that's sort of not aligned and doesn't work and then just like keep trying to like wrap things around it to try to like, fix problems, and every problem you fix creates another problem. And you're like, why don't we just like go back and like, I mean, you can't reinvent the system. You've got to work in the system, but like, let's actually look at what's not working. And instead of sort of putting in like another Band-Aid, like let's think about, is there a better way we can create that pathway? So, spent, about a decade doing that, and then was recruited to Molina as part of the turnaround there. And that was just deeply meaningful for me on two fronts. So one, Molina serves the underserved or the underprivileged. It's largely Medicaid and duals populations, very high need, very high acuity. There are challenge, like it is legitimately hard for someone to get to a doctor's appointment, not because they don't want to go, but because like the bus may not run that often and the doctor's an hour away by bus, right? And like, how do you actually think about, serving individuals that need care so badly and are so constrained? And then, the second piece that was deeply meaningful is it was a true turnaround. There was just so much room for impact because it was, frankly, a company serving so many people that needed it, but where there was real opportunity to change the way things were done to make, frankly, better outcomes for members and better outcomes for investors. And I would say like, to me, the Molina turnaround is an incredible example of how like you can create win-win-wins, right? You can actually like doing better by members does create economic value, right? Creating better operations, like driving efficiency, being smart in what you invest in and not. And so that was my, experience there. And I would say, what I feel really privileged in is every place I've been in my career, I feel like I've learned from great people and learned a different skill set that frankly has been incredibly valuable for the Ilant journey.
Well, all the places that you'd been before Ilant were kind of big institutions, a lot of resources, a lot of people you could learn from, big impact, well-known brand. And so it's not obvious about why you would make a jump into a startup. Was it obvious to you, or what was the spur for it?
No, the spur was personal, right? So, the spur for me was actually, frankly, I've lived with obesity for a lot of my life. And I will say, like every solution out there that anyone has ever proposed, I have done. So like literally every diet you've heard of. I'm not just talking about every variation of the keto diet, including Atkins, South Beach, intermittent fasting. I'm talking cabbage soup diets, grapefruit diets, juice cleanses, CrossFit, Equinox, Soul Cycle, weight loss. I mean, like everything out there, right? And a couple of years ago, I frankly sort of referred myself into evidence-based care. I got bariatric surgery. I got obesity medicine support, and I had a giant realization of just, frankly, how transformative that care was for me, but also how broken the care was. And frankly, coming from a place where I am deeply healthcare knowledgeable, right? Like And like in ways that like I show up to my physician visits with a copy of my, like literally a physical copy of my labs and medical record, because like I assume that like the data didn't make it in, right? And like, for even for me with this like very deep knowledge of the system in all its, forms, it was just not not a great journey. It was a great set of care, not a great journey. And I felt really deeply we needed to do better. And I also felt really strongly that the way we provide better care in this country is by integrating it within the existing system. So working with payers, right, with employers and with health plans on fully insured business. And I just didn't see people getting that type of care in obesity. I mean, I still don't see that in many ways today. A lot of the focus in obesity to care today is direct to consumer self-pay options. And like, to me, we have over 40% of this country with obesity, 70% of this country with obesity and overweight. Like, the solution here is not direct to consumer prescribing of, medication. That may work for a subset of the population. They maybe also will create their own wraparound care, but like, we deeply need something that, provides that care within the auspices of our medical system and our payment systems.
You had basically your own professional experience, personal experience, and a very significant problem to go after, and so naturally made sense to found a company to do that and go after it. But I thought, on the other hand, that I thought the GLP-1s are supposed to solve all the problems and save the healthcare system money, but it doesn't sound like that's how it's working out.
So look, I think GLPs are absolutely transformative, right? In term, I think if you roll back the clock before GLPs, we had basically diet and exercise solutions, which we literally have at least 30 years of data showing that that doesn't work on a population level. So there are individuals that may be successful, but we have run, there are meta-analyses every decade that basically show like it's just not working. And, part of like the thing I found, it would have been funny if it wasn't so sad and scary, is I went to various states to see what initiatives they had on obesity, and you'd literally have like 1990 obesity rate in the state is 25%, goal is to get to 23%, and they're going to like encourage healthy eating and run 5Ks. And then like 1995 obesity rate is 30%. They want to get to 28. And you know what they're going to do? Like encourage healthy eating and like do 10Ks. And you're like, and you can literally like trace these state 5-year plans. And you want to be like, hey guys, like when you were making the plan in like 2015, did you like go back and look at the last like 20 years? Because it looks awfully the same and the numbers are not going the right way. So we had that. We had bariatric surgery, which is incredibly impactful, but not relevant for lower levels of acuity. And, people, especially in the last sort of 5 to 10 years, it's gotten much safer. It's now the safest surgery out there. But before that, there were concerns around safety. And then we had really impactful medication, but which generally topped out at around 10 to 15% weight loss. And so we had a really big gap between sort of where 10 to 15% weight loss was enough and where you needed the bariatric surgery weight loss of sort of the 30%. And so GLPs came in and said, like, look, we can actually get 15, 20% weight loss, which is relevant to the population. But I think a lot of what's happening right now is we're not optimized. So so great that we have this treatment option that creates the ability to transform care. I think the problem is we're not optimizing the value of that treatment on so many dimensions, right? So, even at a clinical level, the GLPs were trialed with, physical activity and nutrition, right? And a lot of times we're actually not doing that. We're not actually sort of seeing in sort of standard care that this is being implemented in a supported model. So even from that perspective, like it's just not enough. It's not, we very much view GLPs as an enabler to care, not as a replacement for care, right? So I think that's a really big miss in the market. And, look, the reality is like, I think that's probably a less compelling pitch on TikTok, which is like, I lost, 80 pounds with this drug and also like all of these things I was doing. And then look, I also think the reality is like, even the best executed solution. So even if we said we have GLPs, every single person's getting the support they need with social determinants of health and accessing food and food changes, and as like all of that is true, the reality is still like you need to match people to the right care. And in order for it to drive value, you have to target the right people. And so I think the reality is when you have 45% of the country with obesity, we're oftentimes not thinking about what is the right care for different people within that 45%. And how do I actually make sure that the people who need the care the most, the very high acuity individuals or ones with multiple comorbidities or really declining metabolic health, are accessing the care. And so I think amazing that we have this sort of transformative technology, but it's not enough. And so much more needs to be done to drive clinical value. And then so much more than that also needs to be done to then also drive financial value.
So it sounds like I can hear your kind of Molina experience coming into play here, talking about what kind of populations are going to get access to care. And then it sounds like diet and exercise, not a bad idea, but it has to be all kind of, put together. And if you've got a better drug technology like GLPs, then they can make a difference. But how do you put all of that together and actually make the numbers add up?
Yeah. So but we're huge fans of physical activity. I don't like the word diet because I think, one of the challenges is people view diets as like, I do a diet and then I become, whoever I want to be. And then I go back to normal life. And similar to physical activity, I sometimes joke, I feel like I get on LinkedIn and people are like, if I wanted to lose 25 pounds, I do 7 simple things. 1, work out for 2 hours a day. 2, like walk 20,000 steps. And I'm like, we have different definitions of simple, but sure. But look, by the way, like eating nutritionally and physical activity are good for you separate from whether you want to lose weight or not, right? Like both have longevity and cardiovascular benefits. So we are huge fans of, eating healthier, finding movement that you enjoy. And we very much view medication and bariatric surgery as enablers to helping people do those activities, which obviously support healthy weight, but also support a whole host of other benefits. And like ultimately, the goal for everyone is not to become thinner. It's to become healthier and live a longer life and be able to play with your grandkids and run that 5K that your state is going to put in place for the 30th time in a row to enable it. So I just want to talk there. But in terms of like, how does it all come together? So one of the things we talk about is what I term de-averaging care. So getting the right member on the right treatment with the right level of support. So let me just take each of those one at a time. So first of all, right member. So I mentioned about 45% of the population has what is considered obesity, which, just to be clear, that definition comes off of body mass index, so BMI. It is a deeply imperfect metric. It's also a very easy metric to sort of measure at a population level. So if you have an individual with a certain BMI, you don't know everything about them, obviously, but at a population level, it's helpful to say, like, where are we generally? The levels of BMI really impact your likelihood of disease and your cost very differently. So 3 levels of obesity: class 1, class 2, class 3. Class 1 is 30 to 35. Class 2 is 35 to 40. Class 3 is over 40 BMI. About 10% of the country, 9.2 exactly, has class 3 obesity. That population has very, very high acuity. They're 2 to 3 times the cost of someone at optimal weight. They have a much higher risk for every obesity-related disease state you've thought of. So yes, diabetes and obstructive sleep apnea and chronic kidney disease and everything else. And so to us, really important to make sure we're getting some of those higher acuity folks. Now, depending on your family history, depending on sort of, some of what is going on, depending sometimes on your race, you can be at a lower BMI and very cardiometabolically complex. So really important to engage those people. So I think one of the first things that's really important is to understand, like, beyond that BMI level. So that more obesity is worse. And so we definitely want to get folks that are higher acuity. but two, that actually BMI doesn't tell you everything you need to know. And so you want to really understand where are the folks that you want to engage proactively now, because you're basically at a fulcrum point, and having sort of, obesity treatment, reducing, that weight, reducing sort of that adipose tissue can really fundamentally change health today, right? So I will tell you, in our population, we see people, we see diabetes remission, right? We see people coming off CPAP machines, right? The question is like, can you get to those people where the treatment will have that very high impact of obesity either now or very near term, and really use the treatment to sort of drive that change in their current clinical condition and the associated cost and where they're trending, right? So that's step one, right member.
Is the right member, is that the most important thing? Obviously, you have to do it first because you don't want to apply the right treatments to the wrong member. But like, right member, is that maybe the number one thing? Because those can sometimes be the hardest people to bring into treatment.
Yeah, so it's funny. No one's asked me that question before. And I think, yes. I mean, if I think about this foundationally, I think what we're seeing a little bit in treatment right now, and now you're going to get a little bit of the insurance wonk, is adverse selection, right? And so I think what's happening, and by the way, this is super normal in an area that's deeply stigmatized, right? So I think it's what we saw in mental health in areas where we've stigmatized people and basically sort of, told them things were their fault or created bad care. The more you had of something, the more stigmatized you were. So it's decently natural for that person to be less proactive. Not every person, but at a population level. So I do think we're seeing some level of adverse selection. I think it's really hard. A lot of times when I hear people talk about obesity, they use averages. So they're like, the average cost of someone with obesity is X. And like, we now have approximately the same level of people with obesity as we have like men in the country, right? And so if I said to you, like, the average cost of men is X, so therefore Y, you'd be like, shouldn't we know something else? Like, are they old men, young men? Like, so to me, like, that average is really problematic. And if you're doing everything on an average and you're not thinking about adverse selection, you're not thinking about, selection, I do think that can be a very big gap. And it's, I think, probably the primary gap in what we're seeing out there right now.
All right, good. I'll let you go on to the second one now.
All right. So let's say we engage people. Like, the second question is like, what treatment do we put them on, right? And, for us, you have to have the full treatment spectrum, right? So some people are going to be really successful on intensive behavioral therapy. So modifying that nutrition, their physical activity, their stress management, their sleep habits. So that's great. And if you can be successful on intensive behavioral therapy, that's what we want to have you on. By the way, many people would love to be successful on intensive behavioral therapy. For other people, they need medication, sometimes a GLP, sometimes a non-GLP. And by the way, I'll tell you, we even see adverse selection sometimes in what people want. So we'll have folks coming in where they say, like, look, I'm strong enough. I know I can lose weight by myself. And we're like, hey, like, you've done like 10 years of diets and exercise. Like, do we really want to try that again? Or should we actually think about, like, you already have obstructive sleep apnea, you're having knee pain. Like, should we think about actually sort of getting, medication support? And then we have folks coming in who, maybe are a little bit lower acuity and they gained, a little bit of weight for various reasons. And they're like, I must get a GLP. And you sort of want to say, like, hey, like, you actually might be like, you may not actually have a metabolic syndrome, right? You may have had stress-related weight gain. It can become metabolic, but are you sure we don't want to try intensive behavioral therapy and modifying some of your behaviors? And so really important that we're getting the right treatment to the right member. And that's not saying, yes to GLPs for everyone. It's not saying no. By the way, it's sometimes saying if you thought you needed a GLP, but you're 70 BMI, that actually bariatric surgery is a much better option, right? And so for us, frankly, like, you asked what's most important, and I do think there's right member, but only if you also get the right treatment. If you attract all the right members and you put them on, the cabbage soup diet again, like, that's not going to drive a ton of value either.
And what you're talking about here, right treatment, is more than step therapy, which is sometimes say, let's do something cheap before we give them something expensive. You try to get it right the first time?
We try to get it right the first time. right? So to me, step therapy is not a great solution. I think step therapy is a great solution if you're trying to avoid treatment, right? Or if you don't know what the right treatment is. So sometimes we'll sort of say, like, look, we don't know, like, there's no data out there. We just don't know. We're just going to step folks through. But to me, your best case scenario is you get, like, obviously it's not possible to get it 100% right. But if you know that someone really needs bariatric surgery, you're frankly wasting money in multiple ways if you try them on a GLP or, another anti-obesity medication or diet and exercise first. In that case, you're both frankly wasting the cost of the treatment that isn't going to work, and they're probably progressing in metabolic unhealthiness over that time. So you're actually now bringing them into that solution at a higher cost, higher risk place. And now I would say on the other side of the equation, if you have someone that has a very high chance of being successful on intensive behavioral therapy, or let's say another anti-obesity medication, you put them on a GLP, one, obviously you're expending costs that didn't need to be expended because it's higher cost. But two, right, like, if that person then says, well, gosh, like, I don't want to be on this medication for life, which we see, you've actually put them at more risk, right? Because, that coming on and off treatment has its own risks associated with it. So to me, yes, if you have no other option out there, step therapy, sure. But like, the right answer here is deeply personalized care. And by the way, right now we personalize care at what I call a phenotype level, right? So we look at a lot of characteristics and we say, like, we're, looking at initial understanding of mechanisms of action of medications, of remission data on treatment, like, where should someone go? But the reality is, like, we actually need to get to a biomarker level, right? Because especially as more and more drugs come out on the market, and this is a lot of where we're going, these drugs have different pathways. By the way, bariatric surgery has different pathways, right, that it's working on. How do we begin and, matching those pathways to the biomarkers and, that someone has to even further sort of optimize their likelihood of success and frankly, the ROI from treatment, right? Because I think you want to manage the amount you want to minimize the amount you're spending per unit of outcome. And you do that both by reducing amount you're spending and increasing unit of outcome, right?
So there's also the time frame for the benefit versus, what's happening on the cost side. And I'm wondering here, you mentioned before, I think something we would all agree with, that you're looking not just for, hey, could I lose 10% of my weight now, but what's my lifetime going to look like? Am I going to live longer? I'm going to be healthy along the way. But chances are I'm going to change insurance carriers, employers during that time frame. Yeah. How do you deal with the near term cost versus the potentially a different time frame for the benefits?
Yeah, absolutely. So look, I would say, David, I think what you're pushing out, which is exactly right, is if we get people to sort of adhere to treatment and sort of maintain the reduction in weight on a lifetime basis, right, it is, quote unquote, positive ROI for everyone as like a human, because life extends, quality of life extends, all of that is great. I will say, like, one thing that we often miss is, like, we've got to adhere to the treatment. So weight cycling, traditionally known as yo-yoing, is a risk factor in and of itself, right? And so, like, we actually don't want, like, this idea of, like, hey, why don't I try? And if it works, maybe I try. Like, we don't want weight cycling, because actually on a lifetime basis, that is, like, in and of itself ROI negative for someone, just literally from a lifetime and quality of life standpoint. But as you rightly point out, within our system, the fact that something pays out in 20 years doesn't make it compelling today, because people switch employers, switch health plans. So I do think that the first piece is to identify the subset of the population where there is near-term ROI. So one of the things we do is we have an analytics engine driven by machine learning where we do claims-based analytics and identify the subset of the population which has positive ROI in 2 years or less. And so what does that look like? So that positive ROI is going to look like taking people off existing medications, It's going to look like avoiding near-term knee replacements. It's going to look like avoiding the second heart attack, right? And again, I think a lot of the ROI work that's been done has said, well, look, if we look at a broad population, it's not ROI positive to treat. There weren't enough heart attacks that were avoided. There weren't, and that's right. Again, that's the problem with using averages. But if you take a population that's highly likely to have a heart attack, to have a knee replacement, that's already on a lot of existing cost and treatment, and you treat them, that population is ROI positive. And David, this is where people often get into like, is that right? Like, shouldn't this be sort of a right to treatment? And my answer is like, look, that's a sort of qualitative debate that like people can have. And like, I have like, there's no, like everyone can have a different opinion there. The quantitative answer for me is if you treat the ROI positive group and you accrue savings, that is an investment that can be made in further treatment, right? So like, we actually have an healthcare system that's not financially sustainable, right? Like people literally can't pay, they avoid treatment because it's so expensive, right? Like if you make the system more financially, sustainable, then like that actually creates opportunities for more people to get care in a variety of different ways.
So where are you finding your initial traction? Are you finding it with, say, the health plans that have this population that's been stigmatized and therefore there's the most opportunity? Is it somewhere else? I mean, what are the ways that you think about going to market, and where are you actually seeing the most demand?
Yeah, so I would say we see a lot of demand from what I would term like sophisticated, innovative buyers, which I almost made sophisticative buyers. So that may be a new patented word. We find sophisticated buyers really great. So that can be sort of, employers that a lot of whom have, experience with their employee population. They're thinking about, gosh, I have a lot of diabetes. I have a lot of musculoskeletal issues, by the way. Like, I'm also paying for those musculoskeletal issues and workers' comp and disability. So we do see interest, in those employers. And what I would say is a lot of times people say like, look, I want to make changes in a financially sustainable way, right? So I want people to get healthier. I want to add treatment, but I also need to do it in a way that my budget works, right? So we find that really resonates. And then I think for health plans, we also see for a lot of health plans, right? Like they've been trying weight loss solutions. They know that they have a share of their book, right? That classic 20% that drives 80% of the cost. And like our folks sit in, many of those folks sit in the 20%, or if they're not in the 20% right now, they're like one hair turn away from heading into that 20%. And so I think the ability for, health plans in particular to be able to identify that group and say like, hey, like you're going to be paying for their treatment one way or the other. The question is, are you paying for something that sort of, reduces the cost trend, that bends trend, or are you paying for the trend to continue to head up? That's deeply compelling. But again, it has to be done financially responsible, right? You have to sort of be able to say like, this is like all the pieces have to come together so that it's great experience and you can get member engagement. So you're, driving quality clinical care and you're getting those financial outcomes.
I've been seeing headlines in Massachusetts about the financial results from the insurers, and they've been losing a ton of money. And it seems to be they're blaming GLP-1s coverage, and even they're, to the point of laying off people and all that. Where is that headed? Are they going to wake up and say, hey, we need an approach like what you're doing? You're just going to cut back on coverage, or what might be their response to that?
Yeah. So look, I think the unfortunate part here is we're seeing a lot of this play out in like classic, not incentive aligned healthcare, which is sort of, a benefit was added. It wasn't always used in a very responsible manner. And so it led to really dire sort of outcomes. And by the way, dire, not just on financial, we oftentimes see like ER rates going up when people are put on treatment without the right support. So like, just so we're very clear, both GLPs and bariatric surgery actually very, very safe in like the grand scheme of things, right? By the way, same thing for other anti-obesity medications like Contrave and Qsymia. But any medical treatment has side effects and things that need to be managed. And so, when that is not done, when you're seeing medi spas prescribing, when you're seeing sort of these direct to consumer do a 10-minute intake and an asynchronous bot is like, you are approved, here's your, payment information to put in, and here's your script, like that has adverse consequences. And I would say, unfortunately, a lot of times the like very quick gut reaction to that is like, okay, now we're going to eliminate all the care, which is like deeply unfortunate because like there are people for whom the care is actually well done, is being managed well. And so I would say gut reaction is going to be pull back in coverage. And what I would hope is, immediately after that gut reaction, we actually have a discussion that says like, look, it's not all or none, right? It is about this de-averaging care, that right member, right treatment, right support. And so we need to drive value through managing treatment. So essentially avoiding putting inappropriate people on treatment and from driving treatment value. And unless we do both, we're just constantly going to be in this push-pull, as opposed to actually sort of carving a path forward to, a healthier and more financially compelling future.
Elina, last question for you is about a book recommendation. I'm wondering if there's any good books you've read lately, or at any point, anything that you'd like to recommend to our audience, or conversely, anything you'd like to recommend that they avoid reading.
It's funny. The last book I read is called The Gambling Man, about Masayoshi Son, and just like fascinating about, how he thinks about the world. It's just a very different mindset. So that's been fascinating. And then right now I'm reading a book called The War Below, which is all about sort of the resources that underpin a lot of modern life. So yeah, those are maybe two really interesting books, nothing to do with healthcare, but fascinating nonetheless.
No, that sounds good. Well, that's it for another episode of the HealthBiz Podcast. My guest today has been Elina Onitskansky, founder and CEO of Ilant Health. Thanks so much for your time today.
Thanks for having me.